Many patients go into the hospital for routine procedures, and not because of the illness, but because of the operation. That's exactly what I explained to my medical students recently. Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best, the hospital is ready, the paperwork is there. Just sign. I used to believe that too, until I started paying attention to outcome. Counting the patients who went in for routine procedures and came out permanently changed. A man who walked in with back pain and left unable to walk. A woman who survived open heart surgery but lost months of her life to complications she was never warned about. Here's what's often not explained clearly. The older the body is, the harder it fights just to survive the operation itself, not the disease. The operation. If you take a new car and one with 200,000 miles and put them through the same stress test, you don't expect the same result. Yet for decades, medicine applied the same surgical expectations to a 70-year-old as to a 40-year-old. Same protocols, same recovery assumptions. That is changing, but not fast enough. Inside an older body under anesthesia, the heart works harder. The lungs take longer to clear anesthetic. The kidneys slow medication processing. And the brain can become disoriented in ways that last weeks or even months. This is called post-operative cognitive dysfunction. In patients over 70, it happens far more often than most people realize. Now, to be clear, age alone is not the issue. Frailty is. Frailty means the body's reserve has dropped below a critical threshold. Around 40% of people over 75 show signs of frailty. That rises to nearly 60% over 85. So the real question is, not can you survive the operation, but can you survive the recovery? Let's start with one of the most common and most misunderstood surgeries. It's one we perform every day, but in frail patients, it becomes a very different story. Open heart surgery. Coronary artery bypass surgery is one of the most common major operations in older adults. For the right patient, it works extremely well. But what is often underestimated is the stress it places on the body. The heart is stopped. A bypass machine takes over circulation. In a healthy patient, this is manageable. In a frail patient with kidney disease, diabetes, or cognitive decline, it becomes a systemic assault. Complication risks include stroke, kidney failure, prolonged confusion, extended ventilation. In frail elderly patients, 30-40% risk of major complications, up to 15% mortality within 30 days in high-risk groups. Alternative approaches now exist in many cases. Less invasive, catheter-based procedures that avoid opening the chest. The key question is, am I a candidate for a less invasive approach? The second is something almost every older patient has been told at some point, that surgery is the solution for back pain. Back pain is extremely common in older adults, and increasingly, surgery is presented as the solution. Spinal fusions, multi-level procedures, hardware along the spine. Some of these operations are absolutely necessary, but for chronic degenerative back pain, the evidence is concerning. In patients over 65, complex spinal fusion shows complication rates exceeding 40%. Common complications: blood clots, infections, hardware failure, adjacent segment disease, where the spine above and below the fusion begins to deteriorate due to altered mechanics. What's often overlooked: long-term pain outcomes are frequently no better than non-surgical treatment. Physical therapy, injections, structured rehabilitation. This is where clinical judgment matters most, because sometimes the best operation is the one not performed. The third is the most difficult to talk about because it involves cancer, and the instinct is always the same: remove it. When cancer is diagnosed, the instinct is immediate: remove it. But surgery is not just about removing disease. It's about preserving meaningful life. In frail elderly patients, major operations can overwhelm the body. Take pancreatic surgery as an example. One of the most complex procedures in medicine. Hours of surgery, multiple organs involved. In younger patients, it can be life-saving. In an older patient with reduced reserve, the surgery may succeed technically, but the patient may not survive the recovery. This is sometimes referred to as futile surgery. Studies show that a significant proportion of elderly patients experience complications they cannot recover from. The important conversation is, what are the alternatives? Observation, targeted therapy, radiation. Options that are often not fully explored. The fourth is often presented as routine, but in the wrong patient. It carries more risk than most people realize: joint replacement. Hip and knee replacements can dramatically improve quality of life. For the right patient, they are transformative. But in older adults with multiple health conditions, heart disease, diabetes, Kidney issues. Risks increase significantly. The major risks include blood clots, pulmonary embolism, infection, pneumonia. The key question is not, should I have this surgery? It is my body prepared for it? Preoperative optimization can change outcomes significantly. Blood pressure control, metabolic health, physical conditioning. And the fifth is different because this is not a choice. It's emergency abdominal surgery. This is different. It is not planned. But in patients over 75, mortality rates can reach 30-50% in severe cases. Not because of surgical failure, but because multiple organs are overwhelmed simultaneously. Inflammatory responses escalate. Organ systems begin to fail in sequence. What matters here is prevention, early recognition of symptoms, and clear discussions with family before emergencies occur. I want to tell you about a patient I'll never forget. His name was Gerald. He was 71, a retired engineer, very sharp. 3 different surgeons had recommended open heart surgery. Same conclusion every time. But Gerald told me something that stayed with me. I'm not afraid of the surgery. I'm afraid of losing myself. He had watched his wife go through a major operation 2 years earlier. She survived, but she never fully came back to who she was. So instead of rushing into surgery, we stepped back and looked at the full picture. His heart, his kidneys, his overall reserve. And in his case, there was another option, an aggressive medical treatment plan combined with cardiac rehabilitation. The data showed something interesting. For someone with his profile, the long-term outcomes were comparable to surgery. So he made a different choice. That was several years ago. And not long ago, he sent me a photo. He was standing at the top of a hiking trail with his 2 granddaughters, smiling like he had won the lottery. This is what I want you to understand. A surgical recommendation is not a verdict. It's the beginning of a conversation. Before any major surgery, ask, what happens if I don't proceed? Is there a less invasive alternative? What does recovery realistically look like for me? What are the complication rates for patients like me?
Which of these surprised you the most? Let me know in the comments. I read every single one. And if you want more clear, honest insights like this, subscribe to the channel. Take care of yourself. Dr. Lucas Weber.